Oops, sorry.
Thank you. 'Cause I think I tried to mute somebody last time and ended up muting myself. Right here. Okay, I will share my screen as I usually do. Then we'll have a look at this. Right, can you all see the slides? And then I always have to work out how to do the slideshow. So this isn't going to take an hour. This is about half an hour of a talk. So I'm going to talk about blood gases. So this is something I've done for the Liverpool CRT a couple of times. So I'm Justine Hadcroft. I'm a respiratory consultant. I work at the Royal Hospital and I'm the consultant lead for the Liverpool Community Respiratory Team. So to paraphrase Raymond Carver, what we talk about when we talk about, he said love, but it's blood gases, isn't it? So when we talk about blood gases, when you get blood gas, it seems to me every day something new's added to that long list of results you get. And it seems to me that the actual blood gases get pushed further and further down. And it just infuriates me that we have to look at a glucose and a potassium and a God knows what else before the blood gases. But anyway, so blood gases are about the pH, the PO2, the CO2, the bicarb and the base excess. That's your blood gases. And then there's other bits and pieces been added over the years. Lactate is quite popular. And there's a lot of venous blood gases get saved in my trust as arterial blood gases because people coming in with possible sepsis get a lactate done. And they get a venous lactate done, but for some strange reason, our ICE system doesn't differentiate between arterial and venous gases. And that's another thing that annoys me. But a lot of things in life annoy me, and I'm just trying to kind of work around my constant irritation. And then there's everything else. And I think at our trust, we might have had 1 or 2 episodes where somebody didn't look at a low sugar or a low potassium and somebody ended up in trouble. So now that has to go right at the top instead of getting people to look at the results and you know, sort things out. We've had to change the whole damn system to accommodate 1 or 2 bits. But anyway, blood gases are about the acidity of the blood, the gases in the blood, and the base excess. In order to interpret blood gases, we need to know what the FiO2 is. So really, a blood gas doesn't make sense unless we know how much oxygen the patient's breathing. Because if we've got a blood gas with a PO2 of 12 and the patient is breathing room air, that's great. If we got a PO2 of 6 and the patient is breathing 40% oxygen, then you've got to ask yourself, what on earth was this person's oxygen before they got put on oxygen? So you really need to know whether they're on air, whether they're on oxygen, how much oxygen they're on, as well as interpreting PO2s. Then I think it helps us interpret CO2s and pHs as well. So if we've got a low pH and a high CO2 and a lot of oxygen, it might be that instead of jumping straight for NIV, we might be thinking about turning down the oxygen and giving a bit of medical treatment and hoping that the acidosis is perhaps iatrogenic and we could sort it out. It's useful to know what the SATs are. So on the blood gas, you'll usually get a saturation and you'll know what the patient's finger probe saturation is. So if those 2 values are quite similar, you can be fairly sure it's an arterial gas. If there's a lot of difference and the saturation on the blood gas is much lower than the finger probe saturation, the likelihood is that could be a mixed or venous sample. So you might be a bit less worried about a low oxygen or a slightly high CO2 or a low pH. And kind of feeding into all that is it arterial or venous? So people who do the blood gases will often know whether it's arterial. Is it bright red when it comes out? Does it come out very quickly? Does it look blue? Does it trickle? And if you're satisfied it's arterial and the SATs are similar to the finger probe SATs, then we're happy to interpret them. If the blood was taken as a venous gas, then we probably don't want to use it to look at blood gases. And if the blood gas was taken as an arterial, but it turns out it's venous because the SATs are wildly different from the finger probe saturation, then we probably can't interpret the blood gases then. So the most important thing is how much oxygen is the patient on. Is it arterial or is it venous? And why do we want to know all this information about blood gases? Why are blood gases important? What do they tell us? So in order for our tissues to work, they need oxygen and other things, but they need oxygen. the metabolic process that's happening in all tissues that uses oxygen is called aerobic respiration. And this will produce waste products, essentially carbon dioxide, and we produce an awful lot of carbon dioxide. And if we allow the carbon dioxide to build up in the blood, that causes the blood to be acidic, and the body doesn't like it. None of the tissues in the body work very well in very acidic or very alkalotic circumstances. So we need to maintain the pH within quite a narrow target in order for the body to function, the tissues in the bodies to function. And in order to keep the carbon dioxide at a reasonable level, we need to eliminate it. So then the carbon dioxide that's produced in the tissue, so muscles, heart, brain, kidneys, everything you can think of, needs to be transported to the lungs. And the way it's transported is by blood. And if there's too much carbon dioxide in the blood, then that blood will be acidic, and that's not good, as I've mentioned, for the tissue. So we need to maintain the carbon dioxide and the acidity of the blood within fairly narrow parameters when we're transporting the carbon dioxide, and we have compensatory mechanisms for if the carbon dioxide is too high or too low, which we'll talk about. So transferring oxygen from the lungs to the tissues, it's carried in red blood cells, and it's also carried in solution in the plasma to a smaller extent, but most of the oxygen is in red blood cells, and the substance in the red blood cells that transports oxygen is called hemoglobin, and that's what we measure when we're doing a full blood count. When we look at HB, it's how much hemoglobin is in the red cells in the blood. And each of those molecules can transport 4 oxygen molecules, so they're quite effective. They can take up a lot of oxygen, whiz it around the body, give it up in tissues, and then the carbon dioxide is transported back, not in the red cells this time, but in solution. When we're talking about oxygen saturation, we're talking about how much of the capacity of the oxygen carrying function is actually being used. So kind of how much oxygen is bound to hemoglobin as a percentage of the hemoglobin's capacity of carrying oxygen, and that's where we're talking about percentages. So if you think about it, we run an oxygen saturation of between 94 and 98%. So most of the time, most of our hemoglobin has got most of its capacity that's filled. So that's quite an interesting thought, I think. So there's not a lot of hemoglobin whizzing around in arterial blood anyway that's not carrying oxygen. And then, as I mentioned, carbon dioxide is not carried back by hemoglobin as much. It's more in solution and as bicarbonate through a kind of a flow equation that kind of has carbonic acid on one side, carbon dioxide on the other side, and bicarbonate in the middle. And we're trying to keep those things in fairly stable proportion. Important things to remember are we get rid of carbon dioxide by breathing it out in the lungs. If we've got excess bicarbonate, that goes out via the kidneys. So we can actually the lungs can act quite quickly to alter carbon dioxide levels. So within hours, a rise in carbon dioxide can be at least partially compensated for. The renal process is much slower. So trying to normalise the acid-base balance by renal excretion or reabsorption of bicarbonate is quite slow, and that can take a few days to actually equilibrate. So our normal pH should be between 7.35 and 7.45, and this is a logarithmic scale. So even though it's only 0.1 difference between 7.35 and 7.45, because it's a logarithmic scale, there is quite a lot of difference in acidity in that very small that very small area. If the pH is less than 7.35, and I think you will all know this is what we call an acidosis. So the blood is acidic if the pH is lower than it ought to be. If the pH is higher than it ought to be, so greater than 7.45, then that's what we call an alkalosis. And the thing that regulates the pH is this equation here. So at one side we've got carbon dioxide, which combines with water to make carbonic acid, and that will break down to form hydrogen ions, and this is the measure of pH, and bicarbonate as well. So if you got too much or too little carbon dioxide, so say if you got too much carbon dioxide, then the carbon dioxide will be combined with water to make more carbonic acid, and then that.
Oh, what's happened? Can you hear her?
No, I think she's gone.
Justine?
Sorry, yeah, I heard that. I don't know how I managed to do that. I didn't click anything this time, so I'm not claiming responsibility. Which bit did you get to? Which bit did you get to? Had I started talking about this equation, or was I still up about acidosis and alkalosis?
Acidosis and alkalosis, yeah.
Right. So if your pH is low, we call it an acidosis. If your pH is high, we call it an alkalosis. And then we do have, we've always got a bit of carbon dioxide, a bit of water, a bit of carbonic acid, a bit of hydrogen ion, and a bit of bicarbonate in our blood in different proportions. And if we can keep these proportions at reasonable level, we will keep the pH in a normal range. If you have, say, too much carbon dioxide, it will try and combine with water, and then that makes carbonic acid, and we don't like too much of that. So if we've got too much of that, it'll start breaking down to hydrogen ions and bicarbonate. So if you end up with too much carbon dioxide, you'll eventually end up going through this and producing more H plus. So that's that controls the acidity of your blood. So this is why if you've got high carbon dioxide, you can end up with an acidosis.
Oh, thank you.
There's somebody not muted, so if you're whispering, don't say insulting things about me, because I won't like that. If you got, say, too little bicarbonate, then what happens is you try and suck a little bit of carbon dioxide across to try and neutralize that, so you'll end up with a low carbon dioxide as compensation. So when we're talking about acidosis or alkalosis, we want to know if it's respiratory or metabolic, and we determine that by working out where the primary change is. If the primary change is an alteration of carbon dioxide, we would call it a respiratory acidosis or alkalosis. But if the primary change has been an alteration in the bicarbonate, then we call that a metabolic acidosis or alkalosis. And metabolic alkalosis is quite rare. There's not really much that causes metabolic alkalosis. So the commonest abnormalities you'll see will be respiratory acidosis, respiratory alkalosis, and metabolic acidosis. Right, so how do we work out what's going on when we look at blood gases, or what do the various acidoses, alkaloses look like? So in a respiratory acidosis, you get a rise in carbon dioxide. And if you remember that equation that went from carbon dioxide and water through bicarbonate, so through carbonic acid to bicarbonate and hydrogen, I already talked about if you've got high carbon dioxide, it combines with water to make carbonic acid, which will break down to form a lot of hydrogen ions. And if you've got too many hydrogen ions, then your kidneys will try and retain some bicarbonate to combine with the hydrogen ions to go back to carbonic acid. So you'll see a rise in bicarbonate as a compensation, but that happens, as I mentioned already, days afterwards. So that's your respiratory acidosis. Your CO2 rises, it has an effect on your pH, and then your kidneys try and compensate by retaining carbon dioxide. In a metabolic acidosis, it's not the CO2 that's the main change, it's a fall in bicarbonate. So if you've got anything that makes you lose bicarbonate from your kidneys, then what happens is you get too little bicarbonate, and so you want to drag some bicarbonate over from the other side of the equation. So what happens is you get a fall in carbon dioxide. Your carbon dioxide is kind of shifted through this bicarbonate, through the carbonic acid stage, to try and compensate for your fall in carbon dioxide. So in a metabolic acidosis, you'll notice a fall in carbon dioxide, and that happens relatively quickly. In respiratory alkalosis, that occurs as a result of a fall in carbon dioxide. And if you get too little carbon dioxide, what you try and do is combine your bicarb with your hydrogen through the carbonic acid part to actually normalize your carbon dioxide. So if you get a fall in carbon dioxide, eventually your kidneys will try and get rid of bicarbonate so that you'll notice a fall in bicarbonate. And a metabolic alkalosis is the unusual one. You'll get a rise in carbon dioxide, a rise in bicarbonate, and there's not many things that do that, and that will cause your pH to rise, and your carbon dioxide will also rise because you'll be trying to combine this bicarbonate with spare hydrogen, which takes you through carbonic acid, and then that breaks down to cause a rise in CO2. Rightio. So then if we talk about normal values, normal pH I've mentioned already is between 7.35 and 7.45. Your CO2 should be somewhere around, we're usually about 4.5 to 6, but different places will vary. So generally between about 4.7 and 6.4. So 4.5 and 6 is probably normal for CO2. PO2 usually about 11 to 14. We don't see many of those, do we really? Most of the gases we do are probably on people with COPD, and they're probably running much lower PO2s than that. Standard bicarb generally runs between about 22 and 29. Base excess, I usually think kind of 2 either way, -2 to +2, but you're allowed a little bit of leeway there. So base usually between -2 and +2. And lactate, if it's measured, should be less than 2.2. So a normal lactate is less than 2.2, and anything higher than that, we need to try and work out why. So because lactate is on a lot of blood gases and causes us a lot of consternation, so presumably you a lot of consternation when you're looking at your ESDs, when you're looking at blood gases to decide if people go home. I thought I'd just mention a little bit about lactate in this talk. So we're all producing lactate as part of our aerobic, but mostly anaerobic metabolism, and especially muscle. So if you do a lot of exercise and your muscles ache the next day, that's because you've got build-up in lactate. So it's a byproduct of metabolism. You get more of it produced if it's anaerobic. So if you're not perfusing your tissues very well, you're more likely to produce lactate. It does it mirrors tissue oxygenation. So if your tissue oxygenation is good, your lactate is probably going to be normal. But if your tissue oxygenation is poor, then your lactate will rise. So elevated levels can be a marker of poor oxygen delivery to the tissue, and that can be because you've got reduced oxygen in the blood, so hypoxia, or it can be due to having normal oxygen in the blood, but you're just not delivering blood to the tissue. So if somebody's hypotensive or got an ischemic limb or ischemic bowel, then the oxygen's not getting through, not because there's not enough oxygen in the blood, but because there's not enough blood getting to the tissue, and that will cause the lactate to rise. We talk about hyperlactatemia with a level above 2 or 2.2 as the previous slide, and then lactic acidosis, usually if it's above 4, and I'd be looking for an acidosis with that as well, but not necessarily. So if your lactate's above 4, then there's something seriously wrong going on, and especially if it's rising. So for our early supported discharge, lactate isn't an inclusion or an exclusion, but if the lactate is high or rising, we ask the discharging team to have a look and try and explain why the lactate should be high, make sure that they are happy that there's nothing serious going on, and then if that's the case, we would take the patient if all other parameters, if all other criteria are met. So we wouldn't refuse to take a patient if they got a high lactate, but we would pass that back to the referring team to explain away and just have another think, because as you know, I think people who don't work in community teams have a reduced understanding of how things work in the community and what's available. So I think it's really quite important to make sure that they're not asking us to discharge patients that are unsafe and outside our criteria. So things that elevate lactate, shock, so essentially anything that drops your blood pressure, cardiogenic shock, so if you had an MI or if you've got bad heart failure, hypovolemic, so if somebody's bled or somebody's dehydrated, septic shock, that'll drop your blood pressure. So you're just not perfusing the tissues because your blood pressure's low, and that'll increase your lactate. I suppose following on from that, post-cardiac arrest, so if you've had zero cardiac output for a while, you're not perfusing your tissues and your lactate will go up. Tissue ischemia, so ischemic limb, ischemic bowel, burns and trauma can also cause ischemia. Diabetic ketoacidosis will cause a hyperlactatemia. Some drugs and toxins like alcohol or cocaine or carbon monoxide can cause lactate, so that's worth thinking about. Some medication such as metformin, especially in renal failure, theophylline can do it as well. Beta agonists, so often the answer to why is this patient's lactate high when we ask the referring team is, oh, because they're on NEBs. And paracetamol, not necessarily in overdose, but especially in overdose, can cause high lactate. So anaerobic muscle activity, exercise we've talked about, but seizures, if somebody has an epileptic fit, their muscles are very, very active, and they might not be able to deliver enough oxygen to support the degree of activity in the muscles. Thiamine deficiency, malignancy and liver failure can also cause high lactates. So that's the run through blood gases. So I've got, I think, 5 cases to put to you with some blood gases and see if you can explain them. So here we have somebody with a pH of 7.5, a CO2 of 3.74, a PO2 of 7.68, a bicarbonate of 23.9 and a base excess of minus 0.5. Does anybody want to go through those? Anybody want to volunteer for this case? So if we're looking at blood gases, we might start with a pH. So this pH is 7.5. So does anybody know, can anybody remember this? Is this a high pH? Is this a low pH? Is this a normal pH?
It's alkalotic, aren't they?
I got very hopeful then because somebody unmuted, but I don't think they're answering the question, are they?
Can you hear me?
Yes, I can. Thank you. Thank you for volunteering.
They're alkalotic.
Yeah, so the pH is high, isn't it? So our normal range is 7.35 to 7.45. So the pH is high. So this is an alkalosis, quite right. What about the CO2? Is that high, normal or low?
No.
It's a bit.
Can you remember what we said the normal CO2 range
Yeah,
was?
so the PCO2 is low, isn't it?
It is. So it should be set at 4.5 to 6. So the CO2 is low. So a low carbon dioxide and a high pH. So an alkalosis. So we're thinking this is a respiratory acid alkalosis, aren't we? Because it seems that the CO2 is quite low. So the bicarbonate is normal, the base is normal. What about the PO2? What do you think about that? Especially in light of these values here.
Because the patient is breathing fast because the PO2 is low, right?
Exactly. So the PO2 should be 11 to 14, we said, didn't we? So this PO2 is really low. So this is quite significant alkalosis and quite a low CO2, and even breathing that hard to bring their pH up to that and their CO2 down to that, they can only get their PO2 to 7.68. So when I see these blood gases, I get really alarmed, and sometimes I feel like the only person who thinks that that's a real problem. But if you imagine if this person wasn't breathing so hard to get the pH up to 7.5 and the CO2 less down to 3.74, what do you think their PO2 was before they started breathing that hard? So this is a person that's in a lot of trouble. So with this degree of hyperventilation, their PO2 is still in their boots. It might have been 4 or 5 before they started breathing. So this is a really sick patient. So I'd be very concerned about this patient. I'd like to give them lots of oxygen because they're not CO2 retainers, so we're probably safe to do it. Lots of oxygen and see what happens to that, but keep a really close eye on this patient. So you can get idiopathic hyperventilation and physiological hyperventilation, and this is a really classical case of physiological hyperventilation. So If any of us were hypoxic, we would all increase our respiratory rate and increase our tidal volume and hyperventilate to try and push our oxygen up. And that would have the result of pushing our CO2 down and pushing our pH up. So this is quite significant physiological hyperventilation. If this PO2 was 17.68, not 7.68, I would be much less worried, and I'd say that's idiopathic hyperventilation, because who needs a PO2 of 17? Something's triggered this patient to start breathing too fast and too deep and get the PO2 right up and drop their CO2 and increase their pH. But this is really worrying to have this degree of respiratory alkalosis with such a low PO2. So this patient might be about to have a respiratory arrest in front of you. So very sick patient. Right, so somebody else can volunteer for this one. Case 2, we've got a pH of 7.35, we've got a CO2 of 7.3, PO2 of 9.6, a bicarbonate of 29 and a base of plus 3.8. Who wants to talk us through this one? Does somebody want to tell me whether the pH is normal or high or low?
pH is normal.
Excellent, thank you for volunteering. So the pH is 7.35, so it's the lower end of normal, but normal. So few, we don't need to panic too much. So this is normal pH. What do we think about the rest of the gases? What do we think about this PCO2?
Retaining.
Yeah, so this is higher than it ought to be. Should be 4.5 to 6, shouldn't it? So this is a CO2 retainer. So this could be one of our COPD patients, couldn't it? Who's chronically hypoxic that retains CO2. If we give them a bit too much oxygen, we might push them into respiratory acidosis. So we want to re-trigger their oxygen sats to a target of 88 to 92. The PO2, I mean, it's less than normal, but it's better than a lot of our COPD patients have. I think that's pretty reasonable. That if this patient was on oxygen, I might be tempted to turn it down a little bit to see if we can just get the pH up a bit and get the CO2 down. But if they're breathing room air, that's not too bad. What about this bicarbonate?
It's only just over, isn't it?
Yeah, so it's perhaps upper limit of normal, perhaps just the lower limit of the lower end of high. So I think this is probably compensated respiratory acidosis. So maybe this patient started off with a slight acidosis related to carbon dioxide, but their kidneys have kicked in and retained a bit of bicarbonate and normalized the pH. So I think this is a compensated type 2 respiratory failure. So it's not a respiratory acidosis, is it? But it's a compensated type 2 respiratory failure. So this is a common blood gas that we would see in a lot of our COPD patients. So that's fairly standard, and the base is slightly positive as well, which mirrors the slightly high bicarbonate. What about this one here? We've got a pH of 7.18, a CO2 of 8.2, a PO2 of 11.8, a bicarb of 22.4, and a base of minus 1.5. Who wants to talk about that pH? Where are we up to there with that pH? Is it normal? Is it high? Is it low? So we know that pH should be between 7.35 and 7.45, so that's low and pretty low actually. So remember, it's a logarithmic scale, so even though it doesn't seem that low on the face of it, although if you're used to looking at a lot of blood gases, then that is alarmingly low. It is quite bad. This patient's got quite a severe acidosis. So then the question is this respiratory or is it metabolic? So what do we look at to decide that?
CO2, right?
Yeah, so we look at the CO2 and we look at the bicarbonate, don't we? So the CO2 is high, isn't it? So 4.5 to 6. So this is somebody with a high CO2. And what about this bicarbonate?
It's within normal range.
Yeah, it is. It's kind of the low end of normal, isn't it? So I might have expected that to have gone up, but I think this is probably an acute respiratory acidosis. So whereas the case in the previous slide had some time to compensate, this person's presumably had an acute rise in carbon dioxide, which has made the pH drop, but not had the time for the kidneys to kick in and start retaining carbon dioxide. So with time, if this patient survived, then I'd expect the bicarbonate to rise and the base excess to rise. But I think this has been an acute decompensation. So this is an acute respiratory acidosis. What about this one? This is a little bit like the first slide, if you remember that one, or the first case, if you remember that one. So pH is 7.53, CO2 is 3.14, PO2 is 24, bicarb is 24, and the base is minus 1.8. So what do we think about this pH? Are we looking at an alkalosis, an acidosis, or is it normal?
Is it an alkalosis?
It is. So pH should be 7.35 to 7.45. So 7.53 is elevated. So that's an alkalosis. So the question is it respiratory or metabolic? What do you think?
Metabolic.
So the bicarbonate is normal, isn't it? So it's probably not a metabolic alkalosis. What about this CO2?
Would you say again they're hyperventilating and blowing it
Yeah.
off?
Exactly. So this is an alkalosis with a low carbon dioxide, so a respiratory alkalosis. But in contrast to the first slide, just look at that PO2, 24. So this isn't a person that's responding to hypoxia and hyperventilating. This is somebody whose oxygen is fine, but is hyperventilating and managed to get a PO2 up to 24, which is a bit ridiculous. Not even mine's 24. So this is idiopathic hyperventilation. So this might be somebody that's come in mimicking asthma or with a panic attack, and they've just, for one reason or another, just started to increase their respiratory rate and their tidal volume. They've increased their oxygen levels and they're blowing off carbon dioxide and cause a respiratory alkalosis. So the old brown paper bag is what this person needs. So this is idiopathic hyperventilation as opposed to physiological hyperventilation, which is a response to hypoxia. So this one I'm not worried about. Probably fine. And I'm going to say she's probably fine. It's often ladies, not exclusively, but yeah, that patient will be fine once the breathing pattern settles down, although they might feel pretty rotten. I don't know if this is this is the last one right here. So this is case 5. So we've got a pH of 7.28, a CO2 of 4.39, a PO2 of 28.6, a bicarbonate of 16, and a base excess of minus 10.4. So what do we think is going on? Is this normal alkalosis or acidosis? This pH is 7.28.
Alkalotic, the one.
Say that again, sorry, one.
Alkalotic? Acidotic, sorry.
Acidotic, yeah. So
Yeah.
pH should be 7.35 to 7.45 and it's 7.28. So this is an acidosis. So then the question is it respiratory or is it metabolic? So we look at the carbon dioxide, and if it's respiratory, we'd expect the CO2 to be high, and it isn't. If anything, it's low. Bicarbonate, if it's metabolic, would expect that to be low, and that is low, isn't it? So that's a low bicarbonate, and that base is really negative. So this is metabolic acidosis.
Could that be someone with kidney failure? So they haven't got that buffering system.
Yeah, exactly. It could be. And then the lungs have kicked in and tried to blow off some of this carbon dioxide that we're producing. So so there's a bit of a compensatory fall in carbon dioxide. So you're absolutely right. This is a metabolic alkalosis, and renal failure can cause that, as can many other things as well. So well done. Well done. Right answers for all of those. So this is my last slide. So to summarise what we've talked about, blood gases tell us about more than just blood gases. Blood pH needs to be maintained for normal cellular function. Changes in pH can occur for different primary reasons, and they're compensated for by this carbonic acid bicarbonate system, which is rapid. The lungs, which can bring about rapid changes in carbon dioxide, and the kidneys, which alter bicarbonate resorption or excretion, but that's quite slow. And it's all about tissue respiration. It's all about how we get the oxygen to the tissues and how we get the waste gases back without causing any deleterious physiological effects. And that's the end. Thank you. So Claire usually stops recording at this point and throws it open to the floor for any questions, queries, comments.